My name is Devin Ryan, and I'm a resident physician at NYU Langone Orthopedics in New York City. Today I'm going to be presenting our study entitled Mind the Gap, a comparison of scheduled and realized hand surgery case duration. We have no financial disclosures. Maximizing OR efficiency is a priority for both surgeons and hospital systems, and has been the subject of numerous studies across many surgical fields. A frequent focus of such research, particularly within orthopedic surgery, has been turnover time and the factors that influence it. This research has also been expanded to analyze other contributors to non-surgical time, including preparatory time and anesthesia time. A relatively underappreciated contributor to OR inefficiency may be the estimation of surgical case duration. This has the potential to cause OR delays which are frustrating to patients and surgeons and costly for hospitals because of staffing issues. The method used to estimate surgical case duration differs across institutions, but typically includes a combination of historical means and having the surgeon estimate the case time at the time of booking. The primary purpose of the present study was to assess the accuracy of hand surgery case duration estimation at a major academic medical center. Our hypothesis, based on anecdotal experience, was that case durations are frequently underestimated. This study was a retrospective review of consecutive patients undergoing hand surgery during 2018 at a major academic medical center. Patient demographic and surgical data were gathered. Relevant perioperative times were obtained, both planned and realized. These included the scheduled time in the OR and scheduled time out of the OR, as well as the actual time in OR, time of incision, time of final closure, and time leaving the operating room. From this data, a number of additional time-related variables were defined and calculated. Scheduled total case duration was the scheduled time in the OR until the scheduled time out of the OR. Realized total case duration was the actual time in the OR until the actual time out of the OR. Preoperative time was the actual time in the OR until the incision time. Surgical time was the incision time until final closure time, and out time was final closure until the actual time out of the OR. As such, realized total case duration is comprised of preoperative time, surgical time, and out time. Finally, delta case time was defined as realized total case duration minus the scheduled total case duration. Therefore, positive values represent cases which took longer than planned, and negative values cases which were faster than expected. Delta case time absolute was the absolute value of the delta case time. Delta case time proportion was defined as the delta case time absolute divided by the scheduled total case duration, and poorly estimated cases were defined as those for which delta case time proportion was greater than or equal to 0.5, i.e., the case time was over or underestimated by at least 50%. The primary outcome of interest was simply the frequency of poorly estimated cases and whether most of these cases were under or overestimated. The influence of surgeon and first case status on the likelihood of poor case estimation was assessed. Comparisons were also planned between well and poorly estimated cases to delineate factors that may contribute to accuracy in case time estimation. These comparisons included perioperative times to assess which components of surgical or non-surgical time contribute to poor case estimation. The sample was then stratified into 3 different groups based on planned total case duration to investigate whether case length influenced the likelihood of accurate estimation. Short cases were those scheduled for less than 45 minutes, medium those scheduled for between 45 and 105 minutes, and long those scheduled for greater than 105 minutes. A total of 3,714 cases were identified. Mean total scheduled case duration was 74.5 minutes, while mean realized total case duration was 78.6 minutes, yielding an average delta case time of 4 minutes. Although this sounds like an insignificant amount, looking at this number alone drastically underestimates the problem. As shown in this histogram, our data demonstrates significant variability as well as right-sided skew, with a relatively small number of cases whose estimations were highly accurate. A total of 19.1% of patients had poorly estimated case durations. Further, nearly 5% of subjects had cases which were underestimated by at least 100%. Finally, out of the poorly estimated cases, 551, or nearly 78%, were underestimated, meaning a vast majority of these cases took longer than expected. First start cases were less likely to be poorly estimated, 16.1% versus 20%. There was significant surgeon variability, with the percentage of poorly estimated cases ranging from 8.1% to 48.6% across surgeons. There was also significant variability based on facility, with 15.6% of cases poorly estimated at the outpatient surgery center versus 21.8% at the orthopedic specialty hospital. Interestingly, there was no difference in the proportion of patients receiving a regional block between well and poorly estimated cases. In comparisons between well-estimated and poorly estimated cases, well-estimated cases tended to have longer scheduled case duration, but shorter realized case duration and surgical time. Well-estimated cases also had shorter preoperative time and shorter out time, but these differences were much smaller in magnitude. The subgroup analysis yielded 1,230 short cases, 1,847 medium cases, and 637 long cases. Of short cases, 22.9% were poorly estimated, compared to 18.6% of medium cases and 13% of long cases. The present study demonstrates that nearly 20% of hand surgery case durations at our institution are misestimated by at least 50%. In our data, the vast majority of these were underestimated, which introduces the potential for significant OR delays. In comparing the specific perioperative times between well and poorly estimated cases, it is notable that poorly estimated cases had scheduled case durations that were shorter, as well as realized case durations that were longer. Further, the primary driver of the increase in realized case duration was surgical time, which was more than 25 minutes longer in poorly estimated cases. These observations suggest that both underestimation of typical surgical time and cases taking longer than is typical contribute to poor overall estimation. At our institution, a suggested case duration is offered at the time of booking based on prior surgeon performance and institutional norms for a given procedure. However, the surgeon is able to modify this time at his or her discretion. On further questioning regarding his practices, the highest performing surgeon in our dataset, with an 8.1% rate of poor case estimation, reported that he reviews his case schedule the day before surgery and emails the surgery center or hospital coordinators with adjustments to schedule case durations as needed. It seems that this simple increase in attention to detail was able to generate much better performance than average. Interestingly, although a common source of surgeon derision, non-surgical time spent in the operating room, including preoperative time and out time, seems to have only a minimal contribution to whether a case was well estimated. On behalf of my team, thank you very much for your attention.